PABST stands for Plate-Assisted Bone Segment Transport.
It's a way for us to treat large segmental defects, typically in the femur, humerus, or tibia, that would otherwise be treated with the external fixation.
So the PABST technique became important for my practice. It actually changed my practice. So before bone transport, anybody with an open injury, with soft tissue defect and questionable bone, I would always wash their wounds multiple times, and I would be very leery about removing bone from any wound. So learning not just the PAPS but the bone transport technique kind of made it, I guess, a lot easier for me to get rid of bone that's devitalized, and it made me feel a lot more confident doing that. The benefit of PAPST is that patients don't have to deal with an external fixator. So a lot of patients during a lot of these procedures are going through a long process of being in an external fixator. Most of them don't like that, and a prolonged period of time using an external fixator is not something that they are excited about having. So having PAPST in my armamentarium of things that I can do to treat those patients is great, and it's good for patients, and it makes me more comfortable taking care of difficult situations.
Previously, treating bone defects for me was with circular external fixation and bone transport. I think that's just a product of my teaching. I think that other ways of doing it, such as an induced membrane technique, also known as masque, I wasn't getting good results with the way that I was doing it. And I was getting more reproducible and better results with bone transport using circular fixation, but that requires a patient to wear a circular external fixator for a long period of time. It's important for my practice because it gives me a different option to offer patients who have these bad injuries. I think that if all things being equal, if your option was either having a circular fixator on your leg or not, most people are going to choose not. Again, there are some advantages and disadvantages of both, but it's just another option that we have for specific injuries for patients. A good patient's going to be a patient that is going to be compliant with what we're asking them to do from using the external remote control and the magnet and the weight-bearing restrictions. I think those are going to be the main things. Everyone needs some type of support at home in order for this to truly be successful. It's difficult for any patient to go at this alone, but good social support, the ability to use the external remote control or have someone assist them to use the remote control, and being able to be compliant with the weight-bearing restrictions.
The indications I've been using the PAPST technique for mostly are acute bone loss. So if somebody gets in an accident, loses a portion of their bone, I've been using PAPST for that. The other ones are for chronic infections. So if they've gone through multiple procedures where I'm debriding their infected non-union multiple times, there comes a point where I decide that cutting that section of bone out is the right thing to do. So I use PAPST in that technique. I don't think I've used it for this before, but I've got a couple patients that I've talked to about PAPST. It's for severe malunions. So you can do a couple of techniques, but one of these would be just to section out that portion of bone, use the nail to line the bone up with the plate, and then recreate that defect with bone transport. So for the doctors that use X-Fix a lot, really the main thing is patient-centered. So again, I don't yet have a patient who's told me how much they love their external fixator. So getting a patient to be happier with having a long procedure like this, I think is very important. Also, there's a lot of other complications that you're avoiding by doing an all-inside PAPS type technique, where you don't have pin tract infections, you don't have to worry about cables and weaving your cables in certain directions. The other benefit of using the magnetic precise nail is you can reverse it. So if you're using an external fixator, specifically with cables, it's hard to reverse that. With the magnetic ERC, you can run a simple program and reverse the bone to get it go in the opposite direction if you're having poor regenerate growth.
So I think PABST would be a better solution for the patient who would not be able to tolerate a circular external fixator otherwise, or for a patient who just chooses not to have a circular external fixator and is looking for other ways of performing their limb salvage or doing their bone transport. Those are the patients that I think are the best candidates for it. And again, the patients who understand the process of what it all entails. I think that for a lot of these patients, circular external fixation is not very well tolerated. And what I would surmise to you is think about what you would want on yourself. I think for a lot of us, having a circular external fixator is a burden. But if the option is amputation, it's a burden we're willing to take. But what if I told you that there was another option? I think that a lot of patients, and I bet you a lot of surgeons, if they had to have their own surgery done, would opt for something like this if it were available.
So I think the benefits of PABST over X-Fix are that it's more patient-friendly. So using PABST, I think, takes a little bit more planning than using an external fixator. I think an external fixator allows for certain adjustments while you're going. Doing PABST, you may not be able to adjust the alignment of the leg as much as you would with an external fixator, but the patient isn't going to have an external fixator on. They're going to have, I think, more comfort by not having an external fixator on. They're also going to have a lower chance of other problems associated with external fixators because the technique is done all inside. There's nothing that's on the outside of the skin, which I think is better for the patient in taking care of their leg during this process.